So for today's agenda, we are going to have just a few introductions and announcements. Our primary discussion today will be on hepatitis C and diabetes, presented by Dr. David Kursky with the Northeast Region Health Office. We also will have two case presentations and then an opportunity for Q&A, and then, of course, our closing remarks. If you have not already done so, if you are interested in receiving a continuing education credit for today's session, you will need to register through the Southeast AIDS Education and Training Center. You can do so by clicking on the link provided or using the QR code. It is not required in order to participate in today's session. However, if you do want to receive that continuing education credit, you do need to register and complete the full session today. You will receive a post-session evaluation survey via email, and then your certificate will come at a later time. I'm going to pause for just a moment as we do still have some people joining. So I want to give them an opportunity to hear the same information. Kimber, do we have everybody admitted so far?
Yes, they're all admitted now.
Perfect. Okay. So I apologize for those that will hear me repeat myself, but just so everyone hears the same information, if you have not registered through the Southeast Age Education and Training Center and are interested in receiving the continuing education credit for today's session, you do need to click on the link provided or utilize the QR code. It is not a requirement in order for you to participate, but it is a requirement if you do want to receive that continuing education credit. After you attend the full session, you will receive a post-session evaluation survey via email, and then your certificate will be emailed at a later time. So as always, we want to take a moment for you to introduce yourself. If you don't care, please put your name, your role, the organization in which you work for or represent, and then if this is your first echo session, in the chat. Also, while we take a moment to do that, if you do have any technical issues today during this session, please private message Kimber Miller. All right, so I do see that some people are dropping their information in the chat. Welcome all. We're glad to have you today. Bear with me as I am having some technical issues myself. I apologize, everyone. Can everyone still see my screen?
Yes.
Okay. For some reason, I'm having trouble being able to switch slides. Okay, I'm going to ask for technical assistance as the facilitator. So I have that I'm sharing my screen, but yet I cannot share or change my slides. Does
So,
anyone?
Lindsay, is this on PowerPoint?
Yes, it is.
Okay. Um, Whenever you are sharing your screen, are you
Mhm.
sharing? So for those that don't know, we work with multiple screens, so sometimes it can be a little much. Are you sharing your actual screen that you're moving the slides on, or are we sharing the other screen?
No, I'm sharing a separate screen, a separate monitor.
Do you want me to try and share my screen and see if it'll let me do it?
Yes.
Okay.
Well, let's see. I might be able.
And so lesson number one today is grace, and we thank you all for your grace
Yes,
today.
I appreciate it. It's never done this to me before. I will stop sharing, Kimber, and allow you the opportunity to try.
Okay, let me get to that folder.
Again, I apologize for the technical difficulties. It's not done this in the past.
Are we on pre-session slides or are we moving on to the presentation?
No, it'll be the session HCV and diabetes title.
The computer must have overheated from the southern heat. Maybe that's what it is. Okay, let me get into presentation mode. It also seems like some things have updated with Zoom. So
Maybe that's the issue. I don't know. It's very bizarre.
yeah. Okay. I am sharing. I'm fixing to share now.
Thank you.
Maybe if I can figure that out. Okay. The tech issue person needs assistance. Okay. Let's see. We're gonna do screen two and share. Okay. Can you see my
Perfect.
screen?
Yes. Thank you so
Awesome.
much.
You're welcome.
And if we can just go to the introduction slide, that would be great. Perfect. Okay, so we're going to pick up where we left off. Again, I apologize. But I did see that several people dropped their information in the chat. We greatly appreciate, as Kimber said, your grace during the technical difficulties, but we are going to go ahead and move forward. So as I mentioned before, today's session is on hepatitis C infection and diabetes. It's going to be presented by Dr. David Kursky, the medical director for the Northeast Regional Health Office. And Dr. Kursky, I'm going to go ahead and turn it over to you.
Okay, thank you. I was happy to see some of our nurse practitioners across the state from the health department joining the call today. Yeah, so I'm a primary care physician. I've been in public health about 20 years. And we've been treating uninsured patients with hepatitis C here in Northeast Tennessee for about 10 years or so, I guess. But yeah, I'm going to be talking about hepatitis C infection and diabetes. You can go to the next slide. Yeah, so I have no conflicts of interest. Next slide. Yeah, my first hint that there was some interaction between hepatitis C and diabetes was with the IDSA hepatitis C treatment guidelines. And you'll notice under monitoring for the in the guidelines that just talks about, monitoring patients that have diabetes while you're treating them for their hepatitis C because of the risk of hypoglycemia and improved, basically, glucose. So we've known that there's been an association between diabetes and liver disease for quite some time. This is from the Journal of Diabetes Care back in 2007, where they mentioned that there's a large number of liver disorders, including elevated liver enzymes, fatty liver disease, cirrhosis, and hepatocellular carcinoma, and also liver failure that are associated with diabetes. At that time, they say, in addition, there's an unexplained association with hepatitis C. It's still not completely explained, as you'll see as we go along, but there's definitely an association between the two. And also that many consider non-alcohol fatty liver disease part of the insulin resistance syndrome. So that's another way that liver and glucose are closely related. Next slide. So, there's a positive association between chronic hepatitis C infection and type 2 diabetes, been demonstrated across different ethnicities and geographic regions in both developed and developing countries. The overall prevalence of diabetes among chronic hepatitis C seropositive populations in multiple geographic areas ranges between 13 and 33%. According to this review back in 2015. They estimate that 20% of chronic hepatitis C patients will develop cirrhosis, which is what we tell all our patients, about a quarter to a fifth, and that as many as 50% of those will have type 2 diabetes, those patients with cirrhosis. So they extrapolated that to being 47 million people worldwide, and about 750,000 people in the US who are expected to develop hepatitis C associated type 2 diabetes. Next slide. So we do know that hepatitis C is associated with various extrahepatic manifestations, and there's a fairly large number of them. So again, it's not surprising that insulin resistance and type 2 diabetes would be among those, especially because of all the glucose metabolism that happens in the liver. Next slide. Okay. So, 3/4 of patients with chronic hepatitis C have extrahepatic manifestations, of which we listed many of them previously. And many times, the extrahepatic manifestations are diagnosed before chronic hepatitis C. Hopefully not so much anymore that we know about those, but it could be that there are patients with diabetes associated with hepatitis C where they have not been tested for hepatitis C. And again, type 2 diabetes is a chronic or a common extrahepatic manifestation of hepatitis C. Insulin resistance has been found to be slightly more common in patients with chronic hep C, even with low degree of liver fibrosis. So you would expect it with cirrhosis, but even with low degree of fibrosis. Type 2 diabetes is more common in patients with hepatitis C related cirrhosis compared to non-cirrhotic patients, which makes sense because of the liver disease associated with diabetes. Type 2 diabetes is associated more frequently, associated with the more frequent occurrence of hepatocellular carcinoma in patients with chronic hepatitis C. Next slide. So again, going back to hepatitis C as a systemic disease, this is basically a review of some things we talked about already. But one thing that was interesting from this review back in 2016 is that they were still talking about that we should treat people early. And one of the reasons is extrahepatic manifestations. Hopefully, we're all treating people early now for a variety of reasons. But back then, at least, it had to be stated that extrahepatic manifestations were one reason to treat people before their liver got too bad. Next slide. So what is the relationship between hepatitis C and insulin resistance? So insulin resistance typically precedes type 2 diabetes. There was 2 studies reported in this review article that reported a positive correlation between hepatitis C and insulin resistance. One study reported the prevalence was high even among non-obese and non-diabetic HCV infected patients, basically independent of obesity and diabetes. 2 studies reported increased prevalence of insulin resistance in non-diabetic hepatitis C infected patients. And though insulin resistance is probably related to the degree of liver fibrosis, again, there's been studies showing can also be found independent of the degree of fibrosis. So hepatitis C and type 2 diabetes, there are several studies that report an increased risk of type 2 diabetes among hepatitis C patients compared to controls such as hepatitis B infected patients and non-hepatitis C infected controls. One longitudinal study found that hepatitis C infected patients had an 11 times higher risk of developing type 2 diabetes compared to the general population. Although there were 2 studies that reported a lack of association independent of liver disease, so like basically in people that did not have cirrhosis, they did not find an association. So, we are still learning more about this, and hopefully our knowledge will continue to evolve on this. Next slide. Yeah, so several studies reported an association with one hepatitis C genotype versus others. So I won't really go into this except to say that this continues to be studied, and there may be more information in the future about whether certain genotypes are at higher risk. Next slide. This is just a summary of those studies related to different genotypes. And again, we won't go into this in depth. You can go to the next slide. So what about the impact of diabetes on hepatitis C disease? There is association between diabetes and hepatitis C, again, reported in numerous epi studies. Diabetes accelerates and exacerbates the progression of hepatitis C disease. The relationship is complex, and again, our knowledge of it is still evolving. And there's many host and viral factors and many ways which hepatitis C interacts with the glucose pathways within the hepatocytes. Discerning how these 2 chronic diseases are related is necessary to reduce hepatitis C and diabetes-related morbidity and mortality. Next slide. So again, both insulin resistance and type 2 diabetes can exacerbate hepatitis C's pathogenesis, including fatty accumulation in the liver, can lead to non-alcoholic fatty liver disease, also known as MASH now, which can further contribute to liver damage and fibrosis. Next slide. So does type 2 diabetes affect treatment outcomes is one question, which is not entirely answered as of yet. So there are several studies to report decreased response to treatment with previous hepatitis C treatments involving interferon. Again, these studies were done in the pre-direct acting antiviral era, and there's still questions as to whether insulin resistance or type 2 diabetes affects response to direct acting antivirals. Just from personal experience, we have not had any treatment failures that I'm aware of in our region in treating patients with hepatitis C that have diabetes or insulin resistance. But again, knowledge is still evolving in that area. Next slide. Yeah, so what happens to hepatitis C or what happens to diabetes after hepatitis C treatment? So there are several studies have observed a marked improvement in blood glucose level, one of which we'll do a case report on in a minute. After SVR, so after someone is treated for hepatitis C. One study reported no improvements in glycolated hemoglobin levels despite hepatitis C eradication, and they postulate a possible long-acting effect of hepatitis C after viral clearance. So again, the jury's still a little bit out on that. Next slide. So yeah, there's accumulating evidence that hepatitis C infection is linked to the development of type 2 diabetes. There's an interaction between hepatitis C infection and development of type 2 diabetes, but it warrants further study just to figure out what the mechanisms are, and whether there's any genotype specific factors, whether we have to worry about it more with certain genotypes over others. Next slide. There was one review article mentioned that there was a study that demonstrated an 81% relative reduction in the risk of developing type 2 diabetes and HCV patients treated with direct-acting antivirals compared to untreated patients. And they estimated for every 15 hepatitis C patients that achieved SVR, one type 2 diabetes case would be prevented. I was not able to confirm that. This was from a review article, and when I tried to access the actual article that it referred to, I couldn't access that article, so I have not been able to confirm that. But I'll continue to look for that or try to access that article. Next slide. So yeah, this is a case study that's actually referenced in the IDSA hepatitis C treatment guidelines when they talk about the need to monitor blood glucose during and after treatment with direct-acting antivirals. Next slide. So this case was reported in the journal Hepatology back in 2016. It was a 53-year-old male with chronic hepatitis C since 1991, presented in 2014 with cirrhosis and insulin-dependent type 2 diabetes, had genotype 1 hepatitis C. Viral load was almost 4 million. Insulin requirements at the time that treatment started with direct-acting antivirals was 18 units of slow-acting insulin a day with 4 to 8 units Q6 hours based on a sliding scale. And they were fairly well controlled. Their hemoglobin A1C was less than 6.5 at the time they started treating with direct-acting antivirals. So short-acting insulin requirements, they noted, started declining day 7 of treatment and continued until day 21 of treatment, when they basically stopped giving sliding scale insulin after some symptomatic hypoglycemia on day 18 of treatment with the direct-acting antivirals. And then their long-acting insulin was also reduced from 18 to 14 units daily. They noted that this corresponded with the HCV viral load becoming undetectable and liver enzymes normalizing after week 2 of treatment. So yeah, that case report is part of the rationale for the practice considerations, which you can go to the next slide. So this is in the treatment guidelines from the AASLD and the IDSA on treatment of hepatitis C among basically the simplified algorithm. One of the things they say in the monitoring section is to inform patients taking diabetes medicines of the potential for symptomatic hypoglycemia, and they recommend monitoring for hypoglycemia. This includes on-treatment and post-treatment monitoring, again, among patients taking diabetes medicines. And they say that real-world data indicate an association between direct-acting antiviral therapy and related changes in hepatic function and alterations in dose-response relationships between diabetes medicines. So, and this, so that reference is from that case I just presented. So they go on to say that to inform patients on these medicines about the potential use, and we do that with all our patients with diabetes that are taking direct-acting antivirals. They note that the frequency and type of contact can be variable, but need to be sufficient to assess patient safety in response to treatment. Next slide. So, yeah, so the Liverpool hepatitis drug interaction tool, which I think many of us use to check for drug interactions among our patients, does mention if you basically, if you look up the direct-acting antivirals, it says diabetic patients may experience improved glucose control, potentially resulting in symptomatic hypoglycemia, and that patients should be closely monitored. The physician in charge of the diabetic care of the patient should be informed if it's not the same person that's treating their hepatitis C. Next slide. I did look up to try to see if there was any drug interactions between direct-acting antivirals that we use most frequently in the diabetes medicines. There's not really, there's a couple of things that came up as potential interactions, but mostly it just said, to monitor for hypoglycemia. So I think it's referring to the same issue that we've been talking about. Next slide. So one question would be, should you screen basically for hepatitis C in all of our patients with diabetes? So there's not any specific recommendation to screen for hepatitis C in patients with diabetes. Diabetes is not listed as a risk factor in the U.S. Preventive Service Task Force recommendations, although they basically do say to screen everybody, basically all adults at least once in their lifetime, and then people with known risk factors to screen more frequently. Next slide. So yeah, the other question is whether to screen for diabetes among patients with hepatitis C. So we do routinely get comprehensive metabolic panels like before, during, and after treatment of patients with hepatitis C, which does include a glucose. So we do have some idea of what's going on with their blood glucose, although oftentimes it's not necessarily a fasting glucose when we get labs from patients. So this review article from 2015 did recommend that screening for diabetes should be performed every 6 to 12 months in patients with hepatitis C in view of the strong association between the two diseases. And then they recommended testing for type 1 diabetes among patients that are on interferon-based therapies. Next slide. So these are the different criteria for diagnosing diabetes. And again, we usually get a glucose, but not necessarily a fasting glucose. We have not been getting hemoglobin A1C pre and post treatment for our patients, but it may be something we would consider starting to do. So I think that's the end of my presentation. Happy to take any questions.
Thank you, Dr. Kursky. So I will pause here just to allow an opportunity for anyone to come off mute or even drop your questions or comments in the chat about today's presentation.
Just step in with an additional comment, Dave. I think that you did a fantastic job as far as reviewing the data in the context of diabetes, both diabetes as far as contributing and also hepatitis C and its impact. I think that we connected offline, and I think that this is really, really important to follow. And I think that it's what's one of the questions that I think comes up a lot when people talk to me about this is how are the new therapies used for diabetes potentially impacting glucose control and these risks of hypoglycemia and other changes? And I'll give my answer, and then I'm going to throw Dr. Allen under the bus, our pharmacist, see what I've observed. But what I've clinically observed is that when we administer insulin, or if we administer medications that cause more insulin to be released, that's when we run into the most problems with hypoglycemia and patients with improving liver function. So that case that you showed, David, I think is a great example of that. And when people are on things like glipizide or other sulfonylureas that prompt more insulin release, that's when we actually worry that improved hepatic metabolism and improved glucose control could actually lead to danger hypoglycemia. And yet, when we talk about therapies like metformin, or when we talk about therapies like GLP-1 agonists, the new medications that actually can help modify diabetes disease activity, we haven't seen, at least clinically in my practice, as much. So maybe, David, I'll first pivot to you. Have you noticed any significant changes to hypoglycemia on patients who are taking any newer diabetes therapies before we pivot to Clark?
For me, no. Well, in our context in the health department, we're primarily using insulin and metformin, and our patients, uninsured patients, don't have as much access to the newer ones. So it might just be a product of us not having access to those. But I do agree that insulin and sulfonylureas, those type of medicines, I would be more vigilant and monitoring for hypoglycemia.
Just to make sure we're all simply, I definitely echo that. But in my diabetes care, and when I'm caring for people with HIV in my Ryan White clinic, is often quite different than when I'm seeing patients in my specialty clinic that might have other insurance or other payers, and that population is very different. Clark, I don't know what you've observed as a pharmacist, but also in observing other providers.
Yeah, so in my clinic, I don't really see that many sulfonylureas like glipizide or glyburide. So I don't really counsel on, or I don't have to mention that with those patients. Insulin every now and then. I feel like most diabetic patients that I have are either on metformin and Jardiance or metformin and one of the injectable medications. So I don't bring it up as much, but anybody who's on insulin or anybody who's on a sulfonylurea, I'm definitely bringing it up. But I haven't really counseled that much on the newer agent just because it doesn't flag as David showed on the interaction checker. So it's not something I bring up every time. Every single time, but maybe I should, just to make sure that when they check their blood sugar, just to be monitoring for that. So that's something for me that I will add to my spiel when I talk to patients who have diabetes and are on diabetic medications.
Thank you all.
I'll defer back to you.
Thank you. There is a question in the chat from a provider. So Elizabeth has asked, are you suggesting to screen all Hep C patients for diabetes now?
Yeah, so my answer would be, I think we are checking their glucose frequently when we get those comprehensive metabolic panels. But, I might consider the patients that we treat when we get the pre-treatment labs to add a hemoglobin A1C and the post-treatment labs. But I haven't seen that as a recommendation. Well, there was the one recommendation from one of the review articles that I mentioned did recommend to do that. Yes.
If we climb into the Wayback Machine and we go back to treatment for hepatitis C pre-direct acting antivirals in the era of interferon-based therapies, screening for diabetes at baseline was actually a pretty common recommendation in different clinical practice guidelines, partly because of the accentuation of disease, but also some of the problems that, David, you highlighted from the data about some newer therapies, and also wanting to ensure that we knew if someone had an interferon-induced form of diabetes, that was something that was identified. That really kind of fell out of the clinical guidelines as interferon faded as part of first or even second line therapy between really 2012 to 2016 was this period where interferon progressively became less and less important in first and second line therapies. So you can still find recommendations for diabetes screening really in that context. But I think, David, we probably are in a similar context that we recommended universal screening for all adults for viral hepatitis. We also generally have recommendations for baseline diabetes screening. Elizabeth, I think to respond to you, I think a lot of it just depends on, is that person in a clinical context where you can ensure that they're going to get diabetes screening? If they're not going to get diabetes screening anywhere else, it's probably very reasonable to get it at baseline. On the other hand, if you know that person has consistent access to primary care, has had it in the past, and maybe less important in the modern times as what was previously.
Thank you both. Dr. Simpson, I am going to hold your question and so that we can move forward with the first case presentation. But we will definitely get to your question. So we're going to go ahead and move forward. So case number 1